Hello, welcome to the Better Outcomes Show, where we explore the possibilities of a new healthcare. Each episode, we bring you a conversation with leaders across the healthcare industry, exploring topics ranging from new treatment techniques and interventions to novel service delivery methods and business models. And now your host, Rafi Salazar from Rehab Practice Solutions, a leader in patient engagement and retention strategy. Let's explore the possibilities of a new healthcare.
Well, hey everybody, welcome to another episode of the Better Outcomes Show. I'm your host, Rafi Salazar from Rehab Practice Solutions. Before we dive into the episode today, where I talk with a former colleague of mine from the university about evidence-based practice and how we can implement it in daily practice, I wanted to take a moment and share some feedback that we received at the clinic that I own, Proactive Rehab and Wellness, here in Augusta, Georgia. Now, we've talked about on the show with many guests about the need to make healthcare more of a human experience, how to remove it from a simple transaction to really a long-term relationship with your patients, with your clients, so that you can get deeper, you can hit those precipitating factors or their underlying factors that might be affecting a patient's condition or diagnosis. So about 6 months ago in October, we began administering a CARE survey, CARES survey. And it's a questionnaire that asks patients 10 questions, and it's all about the interpersonal interactions that the patient has had with the clinician in that encounter, in that healthcare encounter. So everything from, did the patient feel warm, welcomed, and listened to during their experience at the clinic? Did they feel like they were able to tell their story, that their story was heard? And that sort of thing. So we, as just manner of practice, everybody comes in after they have their eval with us and they get one of these surveys. It's completely anonymous. And we received this feedback, which I thought was just a great testament to not so much me, but the staff, the clinicians and the culture that we've built at Proactive. And this person said, as a clinic administrator and healthcare executive for over 10 years, this experience has been refreshing. You all have to share what you have here. You were definitely winning, ! From beginning to end, I had a great experience. And it got me thinking a little bit, like, why was this such a great experience for this patient? Now, I happened to know the patient who was filling out the paperwork, so I followed up with him later at their next appointment, said, hey, thanks for the kind words. I just wanted to find out what was different about this experience or the last time you were here than your traditional healthcare appointment. And she said, quite simply, that she felt that she was being heard, that she was being treated, her words, treated as a human. And it just struck me that, something that we might take for granted as healthcare practitioners, as people running hospitals and healthcare systems and making decisions in order to improve efficiency and to improve the quality of care, we can never forget that at the end of the day, patients that end up in our clinic or in our healthcare system, or if you're a clinician still that's treating patients that end up across the table from you or on the exam table next to you, ultimately want to be heard. And what we can do as clinicians, as individuals, is to harness the power of relationships to help our patients overcome limitations or pain or achieve their goals and chart a real and holistic path towards long-term healing. I mean, after all, that's what real, effective, and value-based care is all about. It's not about, I'm going to build this unit, this treatment code, and get reimbursed because that's standard practice. It's really about helping patients become empowered, if you would, towards their long-term healing. If you want to know more about that, it just so happens Rehab Practice Solutions has a program called the Ultimate Patient Experience. And if you want to learn more about how you can get some feedback like that at your clinic, you can head over to rehabupracticesolutions.com/UPE. That's rehabupracticesolutions.com/UPE. But enough of that. What are we going to talk about today on the podcast? Today, I had the great pleasure of having a conversation with a former colleague of mine at Augusta University. Her name is Dr. Teal Benavides, and she's quite honestly, she's incredible. I love having conversations with her because she's one of those clinicians and one of those academics that really has a firm and solid grasp on research and research process, but she's also able to communicate it in a way and to teach students how to practically apply it in their day-to-day. So I don't know about you, but when I was going to school, when I was in grad school, evidence-based practice and research was one of those things that was highlighted as being important, and it was also highlighted as being very complicated. And many students that I went to school with, we all graduated and we got out in the world, we started treating patients, and we never really felt like we had a firm grasp on how to take this high level, this very heady idea of what is evidence-based practice and take it and apply it into our day-to-day real-life patient experiences and patient interactions. Well, over the course of my time teaching at the university, teaching at Augusta University in their OT department, I happened to be able to co-teach an evidence-based practice course with Teal, and we took an approach that was very different from what was the norm when I was in school, and it was entirely case-based. So the entire course was there was a case example every week, and we used those case examples to build in the skills for the students of how to take, let's say, a research question about what is the most effective treatment or what is the most accurate test or diagnostic tool or whatever it was, and find the research for it, explain it to their peers and other stakeholders, and then kind of roadmap how they would apply it in their day-to-day practice. So it was super eye-opening to me, and I know the students definitely grew in their skills as evidence-based practitioners as a result. So Teal and I were able to sit down and have a conversation about how clinicians can take the steps to implement evidence-based practice in a real practical way in their day-to-day, depending on whatever patient interactions they're having or specific clinical situations, how we can begin as clinicians to kind of build our knowledge base, expand our skills and our scope of knowledge into what is current according to the literature and what is truly treatments and assessments that are effective and shown to be effective by the literature. We also talk a little bit about some of the problems with gating content and open access journals and how to wade through the climate and the environment of kind of predatory journals and all the stuff that's out there. So hopefully you walk away from this interview with this conversation with some real practical tips and tricks and strategies that you can employ in your own day-to-day practice, or if you happen to be a manager or an administrator, that you can help your clinicians implement in their day-to-day practice to help improve care at your clinic or your organization. So without further ado, this is Dr. Teal Benavides talking about evidence-based practice and practically applying it in your day-to-day life. Well, hey, Teal, welcome to the show. How are you?
I'm good, Rafi. How are you? Thanks so much for having me today.
I'm doing wonderful. I'm excited about talking about this topic in particular. So before we dive in, why don't you just start by telling us a little bit about yourself, your work, your research, and we'll kind of go from there.
Super. Yeah. So I'm an associate professor at Augusta University. So pleased to be here. Been here since 2016. I am primarily a research faculty. I engage in research to understand access to care for individuals on the autism spectrum across the lifespan. So really trying to improve how people are able to get access to the things they need in order to maintain their health and well-being. And in addition to that, I primarily teach the research curriculum at Augusta University, research and evidence-based practice. And I've been doing that since 2005 for quite some time, both at a previous institution and here. And I'm so pleased to work with students to see them grow in their knowledge of evidence-based practice, which is the topic of today.
Exactly. Yeah, nice
letting me
segue. And we, I think I've mentioned this in the pre-show, but, just being able to teach with you. So you and I taught evidence-based practice last year, I guess, but this is all like pre-COVID or into COVID.
Yeah.
And I really liked how you were teaching not only what is evidence and what is evidence-based practice, but really giving students like applicable and practical steps that they can take to kind of implementing it, which is what we'll talk about today. So obviously a lot of your teaching is in the whole research and evidence-based practice and kind of developing future students and into clinicians that are going to practice EBP. What are the biggest factors you see in whether or not a clinician, once they're out in the field, is practicing what we call evidence-based practice or evidence-based medicine or whatever the term is these days?
That's a really great question. It's fairly complex. I think that there's a couple of main things that I think affect students' ability to use the skills and knowledge that they've learned about in school when they get out into practice. And when I think about them, I'm an OT, so I'll talk about the intrinsic factors within that new clinician, and then also those environmental contextual factors, if you will, that are external to that new grad. So primarily, when we see students graduate and get into practice, one of the biggest predictors of when they're going to use evidence in practice is whether or not they feel like they have the knowledge and the confidence and competence to easily read and interpret the literature. So right now, the literature on COVID is coming in quite quickly, and it takes a lot of time and energy to read those articles and understand the statistics. And so oftentimes new grads, if they don't feel prepared or confident in being able to read that information and interpret it, they won't do it. And so we really focus on developing those skills in the graduate program, helping students practice over and over and share what they know and then check them on that learning. Another set of factors that really impact students as they graduate and leave and go into clinical practice is their environment that they're in. And so when I talk to old graduates and I read the literature about this, usually the graduates who are continuing to stay up to date are those that are in innovative practice settings that tend to support evidence-based practice. They tend to have journal clubs. They tend to have weekly staff meetings where people are sharing new research or talking about research. Those settings also tend to involve clinicians in research. So sometimes those environments also are engaged in collaborating with researchers to understand the interventions and the assessments that they're using. So the environment is really critical for those new grads. And it's one reason I always encourage our students to ask their potential employers what kind of resources they have to engage in evidence-based practices.
Yeah. So you laid out the groundwork here. There's some intrinsic factors, kind of the skills, the competence, and then there's the external factors, kind of the environment. So let's dive a little bit into the intrinsic, and then we'll move into that extrinsic factor. So what might be some of the reasons where a clinician or maybe a new grad doesn't feel skilled in the ability to kind of read and interpret and implement the research?
Yeah, that one's challenging because I think I sometimes struggle with reading new statistical approaches in an article or understanding some of the more complex things that researchers are doing. Every day, research is not a static thing. There's new research designs that are being used and new statistical approaches that are being implemented. And I think that oftentimes the being able to read and interpret the results in the tables confidently is a challenge. I think for a new grad in particular, it's daunting. And one of the things that I don't know if you've found this to be true, but sometimes the discussion of a research paper is not exactly aligned as well with the results. And when people skip over that results section, maybe because of lack of competence or confidence, it can impact what they do. They might misinterpret the article. So I think that the confidence and competence in interpreting statistics, understanding p-values, effect sizes, all of those things are pretty challenging for a lot of people.
Yeah. And you kind of mentioned it too, like if you skip over the results into the discussion, I'm assuming you're talking about people that are also just maybe just screening like abstracts, and they're screening abstracts looking for something, they're treating a patient with COVID, or maybe they're treating a new novel, a diagnosis for them. So they're combing all these abstracts looking for evidence, and they might just not be super, super confident in even how to filter out the bad abstracts, right?
Oh, I think absolutely. That is a mindset that you can get into, right? Which is, I'm looking for certain evidence to support what I'm doing. So I'm going to read the abstracts, and I'm going to select the ones that support my positionality on a particular approach. And I think that's a dangerous trap that people can get into if they're not going into it with the mindset of really wanting to understand, is this approach or is this evaluation going to be effective, or is this evaluation going to be reliable or valid? So I think you bring up a really important point, that seeking to confirm one's position is an intrinsic factor, right? I mean, if we go into the literature hoping to find something, we're probably going to find something to support it. But if people are not being critical thinkers when they're reading, that's dangerous.
Yeah. So sort of that confirmation bias, right?
Oh yeah, definitely. I think we all do it, but we just have to remind ourselves not to.
Yeah. Are there any tips or tricks you got for students or new grads that are getting into this, how to kind of check themselves for confirmation bias, other than trying to be more self-aware?
One of the things that I frequently encourage is don't just discard a study because it doesn't find statistically significant results. I think automatically people look to see, are the p-values statistically significant? And if it's not, they assume that it won't inform their understanding. But in fact, I ask them when they do that, I ask them, well, if there isn't a true difference, isn't that just as important as if there was a true difference? So, making sure that we aren't just automatically ditching the studies that don't find differences between a treatment and a control group. I mean, one reason is maybe the sample size was too small and a larger study needs to be conducted. But another reason could be maybe there aren't true differences.
Yeah. Maybe it's an ineffective treatment
between two different intervention approaches. Right. So, that's one automatic thing that I think people do, is just ditch a study because they don't find statistically significant findings. But that's one way to prevent confirmation bias, is to be open to studies that find significant and non-significant results, and then really dig in to see why.
Yeah. Well, and I think you and I have had this conversation before too, about the skills of clinicians and all that. And I think that we do need to draw a delineation between new grads and new practitioners that are coming into the field, which I feel like are light years ahead in their ability to determine what is a statistically significant change. Like they're able to read statistics and p-values and really understand what they mean. We've got a whole generation of clinicians that might be near the end of their work life, if you would. They're kind of phasing out of the profession, but they're kind of in charge, right? They're the management of these new clinicians. And they're coming from a standpoint of just not having the skills, right? They were not really trained in school, because evidence-based practice is something that's kind of been pushed to the forefront over the last maybe 15, 20 years, but there's a whole crop of clinicians that went through school that didn't get that training, right?
Yeah, the first EBP article in OT that really emphasized this was a Eleanor Clark Slagle lecture back in 2000, I think. Margot Holm did a Eleanor Clark Slagle lecture on evidence-based practice. So, we are talking about 20 years ago when it first became a big push in our profession. It's been around for quite a bit longer than that. in other professions, other medical professions. But you're right. I think that for practitioners who've been out in the field for at least that long, they've had to either teach themselves how to search for the evidence with all these new electronic search databases, how to read the evidence. And I don't know about you, but when I'm looking at the continuing education courses, I'm not seeing a lot out there as to how to interpret the evidence. I'm seeing a lot of people presenting that their approach is best, but I don't always see people teaching some of those thoughtful approaches for really digging into what you're reading. So I agree. I think there are going to be some generational differences as the cohort of people who are learning and applying evidence move up into different positions.
Yeah. Well, and I think part of that too around continuing education courses, I wonder how much of that is like regulatory, like for an OT in Georgia, for example, to renew your license, you get so many hours that you need to do. And the bulk of those have to be direct patient care. And whether or not learning how to read research counts as direct patient care really dictates whether or not somebody clicks purchase on that course, right?
Absolutely. Yeah, I didn't even think about that, but you're completely correct that people are looking for those more hands-on types of continuing education courses. And hopefully those educators are including the evidence to support what they're teaching. But there isn't any substitute, I think, for just reading the literature and staying connected to that. Yeah, that's hard.
Yeah. And then kind of in that same vein, it kind of segues into those external factors. So you've got all these clinicians that might not, let's just say, not value the understanding of research, or maybe they're just intimidated by it because they don't have the skills or whatever. And now they're managing these essentially big departments, whether it be rehab departments or hospital systems. And we're creating environments that may or may not be beneficial for new grads and new clinicians to come out and practice evidence-based medicine, right?
I think it depends on the setting. I think you're right. I think that if it depends on the manager and it depends on the setting. I think that in some settings, the management has to stay up with the latest literature, even if it wasn't something they engaged in. So for example, I was just talking to colleagues who are up at the Philadelphia Hand Center and graduated long before EBP. But in hand therapy, for example, the surgeons are using different approaches. The healing times are different because of new materials or new suture approaches or whatever it might be. And the hand therapists are really on it. I mean, they have a ton of new literature all the time to synthesize and adapt clinical protocols. And so from that perspective, that environment, even though there are a number of older clinicians, they have been, I don't want to say forced, but it's part of the ethos of that environment, right? And again, that's that external support. So because it's emphasized, because it's probably part of that team approach where you have the physician, the surgeon, the therapist, the hand therapist, all talking about evidence. If the therapist isn't up on their EBP game, they're not going to feel very much a part of that team. And so I think that in those types of settings, the clinicians are staying up with the literature, in fact, probably much more than in other settings. I think, though, that if you have clinicians who've maybe been in private pediatric practice, are relying on older literature, maybe don't have the resources in terms of funding to pay for access to articles that are sometimes $30 or $40, then it becomes a lot harder. And quite frankly, the evidence base on that is slower than in hand therapy. The evidence in pediatrics is much slower to come out. I'm still reading things that are talking about the same thing that we published 20 years ago. And I don't understand why we're not seeing advances in pushing the envelope as to what we need to advance practice in certain practice areas. And so it could be the clinicians, right? But it could also be the way funding is structured to support different practice areas. It could be
or what gets published and what doesn't get
published. Mm-hmm. And so I'm not as quick to put the blame on clinicians older, although I do think that there are some things that reinforce people not seeking out the literature, you know, like the financial pieces or the lack of literature. Every time I go to search, I'm not finding very much, right? I mean, I think we hear that quite a bit in certain practice areas. For quite some time, I think mental health was quite stagnant, but now it's growing again.
Yeah.
In terms of
Well, and you bring
health.
up a good point too about the financial thing too. Like when you're talking about finding maybe three or even just 3 or 4 articles and they're $50 a pop, $40 a pop, whatever, you're talking, a couple $100 to figure out whether or not this treatment technique is even worth it. Like it's hard for a clinician that's may or may not be being paid in addition to what they're currently, their salary is. Like a lot of people don't have a little stipend to go do research, right?
Right. And I think that, this brings you back to that regulatory piece, right? Which is that every clinician is required to engage in continuing education. I was pleased to see that in Georgia and many other places, and even for NBCOT licensure, doing a critical review of an article counts towards those elements of maintaining one's practice, because it is expensive. I mean, it is a financial investment, but those clinicians, if they're seeking out evidence and they don't have the funds to do it, they need to partner with academic institutions so we can send them our students.
Yeah.
And then the students can be working to help promote the use of evidence, right? I mean, partner with an academic institution, take fieldwork students, and then ask your students to obtain access to the articles you need or want.
Yeah, that was our strategy a long time. We're getting some students from y'all actually in the next couple of weeks at my clinic, and I'm like, start thinking about what we wanted to pull research wise.
That's right. That's right.
I think we talked offline last time, kind of around this whole issue of access, right? Like some organizations, publishers, that sort of thing, are really restricting access to their articles. They see them obviously as intellectual property, and a lot of times, like the researchers aren't getting those $40 for each time that article is sold. That's going straight to the publisher. So there's like a financial incentive to kind of keep those paywalls up. But during the last year, there's kind of been some opening of that, right? Like some more open access journals and that sort of thing.
Yeah, I'm not sure to what extent COVID has impacted. I'm sure you'd probably know a lot more than I. But the open access movement really started, I want to say, back in 2010-ish. People started really talking about open access journals, and it's hard because for researchers anyway, there's a really unclear line between predatory journals that are just seeking to take your money, and it doesn't matter whether or not it's a quality article. It just matters that you pay them money and they'll put
pay
it
the
out
publish
there.
firm or something like that.
Publish. But there are some reputable open access journals like British Medical Journal and PLOS, PLOS Medicine, a lot of those. And in those situations and those types of reputable open access journals, the researcher pays, or sometimes it's a funder of the that's paying the researcher to do that work will pay, and usually the article costs about $3,000 to publish. So if I was to have an article accepted, those journals would say, do you want to publish it open access? And if I choose yes, I pay a fee of about $3,000. And then everyone can get it free of charge. And so the researcher doesn't, by the way, make any money even off of those open access ones. The money is still being paid to the publisher. It's just making it freely available to everyone else, which is a good model to follow, because it means that the research is more quickly implemented into practice. I think the going number right now for time between a study being published, it turning into a practice, something that's done, is 7 years. Is that what you've also read?
That's correct. Yep.
Yeah. Which is a long time, especially since those researchers have worked hard to get those things out there as quickly as possible. But practice change takes a long time.
Yeah. Part of that is knowledge translation and all that as well. Part of when I think about this open access, movement, part of me is very excited because I believe like access to information should be free, and the internet has allowed us to bring information to the masses. But how do we prevent kind of the pendulum from swinging the other way, if you would, from this one area of it's very locked up. You need to pay to get your research articles, almost to the other way where it's kind of like the Wild West, and like anyone with a blog can pose that something's accurate when it's really not. Like how do we kind of wade through the vast array of open access journals and find which ones are reputable, which ones aren't, and where we should be spending our attention?
Oh, that's a loaded question.
Yeah.
That's the $1 million question right there. If you can figure that out, I think, particularly in COVID, that's been challenging. And here's why. In pre-COVID, the need or desire for certain types of research didn't push sort of the speed of publication up so much. I mean, there's obviously some types of research that need to be published quickly, but there hasn't been a need for something in one particular area like COVID. Now people need information, and they need it quickly because people are sick, ill, and dying. And so what ended up happening over the past year is we saw a shift towards people posting pre-publication results, so non-peer reviewed evidence on preprint servers, with very little oversight of the research. There have been a number of retractions of that research after it's been put out there, but people still continue to rely on it. So that's a concern. And you're asking, how do we prevent that from happening? And we're seeing it happen right now because of COVID. But I don't know if we're going to be able to put that back in the box of this is something we aren't going to be doing. I think a lot of people have found value in posting their results into a preprint server. It increases the access, it decreases the time from finishing a study to publication. But it makes it harder for clinicians to know what's reputable. I mean, that was your question. How do we know what to select? What has been peer reviewed? There used to be a predatory journals list that was published. And some of the journals that were on that list sued to have their names removed from that list. So it's no longer publicly available. But there are some sort of websites that will tell you, like, these are predatory journals. But I notice our students pulling from them. I mean, I notice our students don't know. I mean, it sounds like a great journal, like the International Journal of whatever. And there's really no clear indication that it's a predatory journal that is pay to publish. I don't know. What thoughts do you have on that?
Well, it's a complicated issue, because I do think that obviously during something like the pandemic, where we're trying to get information out there very, very quickly, like, we can't wait for the peer review process, right? And there are problems with the peer review process as far as, whether or not something decides to get published because, well, the results are or are not politically, motivated and all that. But I do feel like for the vast majority, just from like a behavioral psychology standpoint, people go for easy, right? And if the ask of evidence-based practice is already hard enough. So then to put the added burden of, well, now you need to go through and like look through these preprint servers and determine for yourself whether or not this is research and data that we should be using, is a very hard sell, I think, for people. And what you're probably going to have is people that scroll through, they see something, and again, we're humans, cognitive bias, confirmation bias. They'll say, oh, look, this is data from a researcher. It's got to be right because it confirms my belief, yada, yada, yada. So it's a tough nut to crack, for sure.
I know. I'm not sure what, I think one thing we're going to have to do is start teaching our graduates how to tell whether or not something is a reputable journal, right? We teach people how to critique study design and read statistics, but I mean, there was I'll have to share with you, there was some research done where a group of researchers said, we're just going to see if we can scam the system. We're going to write up a great sounding study, right? It sounds great. Study design sounds perfect. We're going to make up all the data and we're going to try and get it through peer review process. This was because they wanted to show that it doesn't quite matter
Yeah.
what you do as long as you write the right things, right? You use the right words, and they were able to get it published. And then they revealed that this is a bogus study, and it was a real eye opener for people. Like on my end, I do editorial board. I'm on an editorial board of 2 different journals, AJOT and the Autism and Adulthood journals. And we got notice that this was happening. So when we read studies as, an editor, we have to be thinking, is this a real study? I mean, is this plausible? Is it feasible? Are these real people? Is this their expertise? Before we send it out for peer review. But, if studies are being posted on a preprint server, there isn't anyone doing that, right?
Yeah.
People can really choose to put whatever they want out there. So I think, my recommendation is for clinicians, continue to rely on peer-reviewed evidence. Unless you're really confident in reading research, I wouldn't use some of that preprint server stuff, honestly.
Yeah. Make sure it's been vetted and validated.
Make sure it's been vetted and validated, or rely on a group think. If you find a good article and you're not super confident in it and it's a preprint for something new like COVID, critique it with a group of people so that you're aware of the potential major biases that are at play. So I mean, I don't really know if there's going to be another solution.
Yeah.
Yeah.
Well, that's as good a solution as any, right? The last question here that we got is, what practical strategies could you give a clinician to implement kind of the habit of, not just the habit of evidence-based practice, but more specifically the habit of searching for and utilizing the evidence, right? Like, I think when we say evidence-based practice is a really big kind of nebulous term, but really what we're talking about is searching the evidence, kind of critiquing it, and then using it or not using it, right?
Yeah. I mean, I think the most effective tool is practice. I mean, how many times do you have to taste a new food before it's okay to you, right? How many do you have to engage in a new habit before it becomes second nature? So what we try to do in an education setting anyway, is just ask students to practice it. Low stakes practice, search for the evidence. We're going to give you 10, 15 minutes to find an article for this clinical case, and use those skills. The more people practice, then the more quickly those habits will become ingrained. It won't be as hard. Usually when students come in to a program, it takes them about an hour to an hour and a half to do a search of the literature. My goal is by the time they leave, about a year later, they can do it in about 10 to 15. And we get there. So practice, that's the first strategy. The second strategy is to do it in a group. So I think it's always more fun to do journal clubs with others. And there's a lot of evidence actually to support journal clubs as an effective way to engage in evidence-based practice. So sharing the burden of finding the evidence and critiquing it and then talking about it in a rotating way in a journal club helps people to stay engaged without having to be the one responsible for the critique every week. So I think employers and clinicians, if they can find a group of people they enjoy meeting with and talking with about this, make it fun, bring food, do something that is enjoyable, go to the coffee shop. I mean, there's other ways to make it fun too, but this is a family show. No. Bring a bottle of wine, but no, you can edit that out. I think that the social aspect of it, and what we gets at that to confirm your thought, but others might be reading it with a different mindset, and so doing it in a social setting is helpful. So practice, engage in journal clubs or other social reviews of the literature. And then the third thing I'd recommend clinicians do is partner with an academic setting who can both support your evidence needs. We talked about finances being a burden. If you take a level 1 student once a year, you can ask that student to engage in this process. They should be skilled in it, and they can help you find evidence as well. So I always think that students are a really helpful way of promoting that in settings where there might not be the financial or time resources. So take fieldwork students and partner with an academic setting. And academic settings are willing to do that. They want to do that. We want to see those collaborations happen. So those are the three main things, I guess. And then I guess, maybe the fourth one, and this is a little bit harder to do, is when you're interviewing for a new job, ask, demand, put it in writing.
Yeah.
I want access to X amount of money per year to allow me to purchase articles, or I'd like to purchase a subscription to whatever journal. And I'd like that to be part of my compensation package. We don't see people asking for what they need, right? I mean, I think that should be a part of our daily practice. And then if the employer's not providing it, you can ask. So that's something that clinicians can do. I think that's a little bit harder of a sell in some places, but those are the things that I would think of doing.
Yeah, no, that's a great list. That's awesome. Well, Teal, thanks so much for taking the time and being on the show. If people want to, find out about you and your research, where can they do that?
So our Augusta University faculty profile pages are up. I'm happy to share that link with you. And you can also reach me at tbenavides@augusta.edu. I'm happy to share that email with you as well.
Sure. Yeah, we'll link to all that in the show notes. Well, thanks so much.
Awesome. Thank you again, Rafi. It was good to see you and talk about this important topic.
Yeah. All right.
Thanks for having me.
Well, I hope you enjoyed that conversation with Teal about how you can take this giant, somewhat intimidating notion of evidence-based practice and apply it in day-to-day practice. Or if you're like I said, if you're an administrator or a manager and you have a team of clinicians, how you can mentor them into making evidence-based practice part of their daily routine, part of their professional development, if you would. Because again, we're all trying to do what is best for the patient, and that means making decisions based off the best available evidence at the time, right? I think listening back to the conversation, it became, again, really apparent how much of a multifaceted issue this is. It's not something as simple as training clinicians on how to look up the evidence or do anything with the research or use the keywords. There's also the added complication of the time that is involved in doing it, the resources that are available. I mean, some of these studies, $40-$50 a pop to buy a research study to read it. Like, you do that for every single patient of your day, and maybe you're looking for one or two articles. That adds up really quickly. And then it doesn't get any easier by the fact that there are these predatory open access journals. So it's definitely a tough nut to crack. But I'm very grateful for Teal for taking the time just to share with us some of her insights and her tips and strategies on that. Just because it's a really important topic that has direct impact on the quality of care that we deliver to our patients. So yeah, that's all I've got to say about that topic. If you like the show, head on over to Apple, leave us a rating and review. It helps people find the show. If you want to get notified when we drop new episodes, which we drop usually every other Wednesday, we release a new episode with sometimes a bonus episode in the off weeks. You can head over to www.betteroutcomes.show, and you can sign up there for the email list, and we'll shoot you out a copy of or a link to the episode and a little synopsis about it right to your inbox. So can you follow us there and keep up with what's going on. If you want to learn more about how RehabU Practice Solutions can help you increase patient engagement, decrease your cancellation and no-show rates, and garner some reviews and feedback like I read at the beginning of the episode, you can head on over to www.rehabupracticesolutions.com/UPE. That's rehab, the letter U, practicesolutions.com/UPE. Until the next time, guys, be safe, be healthy. I will talk to you then.
Thanks for listening to the Better Outcomes Show, where we explore the possibilities of a new healthcare. Our hope is that you walk away from each episode informed, equipped, and empowered to push the boundaries in your own practice or business. We want to give you the tools to help you build strong, long-lasting relationships with your patients and clients, helping meet their goals, improve their health, and achieve better outcomes. Learn more at www.rehabpracticesolutions.com. We'll catch you on the next episode.